Hi, everybody. Welcome in the next session of the Patient Engagement Open Forum, Navigating Digital Health and Shaping Guiding Principle for a Responsible Data Model. So I'm Nicholas Brook. I'm the Director of Patient-Focused Medicine Development, and I'm really happy to have you here and to discuss about digital health and the patient engagement in digital health and all the challenges we are facing. So just before we get to our specific session, I just wanted to remind the principle about the Patient Engagement Open Forum. So basically the idea is really to dedicate a forum physically that we are face-to-face when we can, but that we are virtually this year. And we dedicate it to a multi-stakeholder platform to actually develop better patient engagement and stronger patient engagement across health systems. So the goal is really to have a holistic perspective and to have a representation and a participation of all stakeholders. Next slide, please. And so before we get started, just a couple of housekeeping rules. So the goal is to have you on board to engage. So we will have a first phase of the session where our speakers will present learnings or projects that they have. But then already there, we would like you to use the chat to share some insights or to use the Q&A to put questions. So please put the questions in the Q&A so we can manage them and share them with the panelists. You will be on mute. The session is recorded. And so well, let's work together. Next slide, please. You have for the Q&A a button at the bottom, as you see in the red circle. So yes, we will basically, when we see the Q&A coming in, we will wait the right moment to answer it. We will try our best to address most of the question that you ask. Next slide, please. Later on, after the speakers, we will also use an online tool to get your insights based on the various input we would have had before. So in due time, you will have a link in the chat to go to GroupMap, and we will ask you to actually contribute to shape what could be the role and the value of patients in the various decision point for data and data models. Next slide, please. So with this, I'm super happy to actually introduce you to the speaker we have today. So we will start with Nevin, and Nevin will come, and for birthday, actually, for her birthday today, she decided to come with us and to share about sharing data in a global pandemic, COVID-19. So she has been very active as part of the ICODA project to actually develop a global center, data center for COVID-19. And actually she has observed, she tried to walk the talk, and she has observed and made a lot of learnings out of it. That's what she's coming to share with us today. And then Matthias Rose and Tom Metcalf will join in a presentation that they will do together. And actually, they are representing a new IMI project, IMI H2O, and they will actually explain what's the thinking, what's the issue that H2O is trying to address. And they are coming to us today to actually see, okay, how can we make sure that you have a good representation in our various work streams and make that happen. So we will welcome them for the second part of the presentation. And together with me, I'm very happy to have Jan Geisler, who was there in a previous session. And he will be there to react to the presentation and to actually give a patient perspective to the key question that Nevin, Matthias, and Tom will actually introduce to us today. So we will get started, but before we get to the speaker, my idea was to briefly remind you what we have done in the last session in April about digital health. So next slide, please. So we had 4 speakers. The first one was Andrea Downing, and with a very specific profile of being an e-patient security researcher and patient advocate. she came to us to do, and I'm quoting her, to do a call to arm to actually prevent what's happening today. And she has been giving example of Facebook, for example, with our personal data being used, researched and captured without us knowing, and at a very big scale. We had the second speaker, Charles Stewart, that actually illustrated the potential of data and digital health in personalized medicine with some specific project, and he was discussing actually the potential, but also the need of awareness, education, and the need to develop new systems to face all these new potential of precision medicine and digital health. Next slide. We had also Adley Clark, and she came to actually from Pasteur Cures, and she was very focused on what should be the digital health systems of the future and the role of trust. I'm pretty sure that trust will come back today in our discussions, and that's a key element to move forward. And then finally, Jan, who is today with us, came to talk about his passion about elephants. And so basically, he was arguing for a new data model with a key role for the patient community, where actually the patients are really at the center and helping, connecting and harmonizing all the different stakeholders. The model as he presented today will have mice as much smaller in comparison to the elephants. And so the wish and the model we want to design together will be to put the patient community with a similar share of voice than the other stakeholders, and in a kind of coordination or central role in this new data model, the collaborative model of the future. And so we have asked the audience to give some input, and actually a few we have captured the different input from the audience to actually complete. So what should be done? What are the key issues, and what can we do to move forward in terms of digital health and patient centricity? So I will just go through them briefly. So how can we shape a data model for decision making with patients? So it's not only about designing and generating the data, it's also about taking decisions with the patients. Articulate some guiding principle for data privacy. Build also a curriculum that reflects all the knowledge we have already, so we can help the different stakeholders and the patients to have a better understanding about digital, what is at stake, and what's the literacy we can develop around that topic. We also have, of course, the issue which is very present on all aspects of health today, the discrimination aspect of health. So how can we make sure that digital is a solution to reduce it, not to increase it? And develop further patient education program on digital health to make sure they can contribute to the right level of expertise. I'm sure Jan will have some specific points on that. And finally, before we get started with Naveen, I just wanted to articulate 4 hypotheses of work for our session today. The first one, and I'm stating the obvious, but that will prevent us to restate the obvious in the presentation. So data is essential resource for patients, researchers, and decision makers, and to drive innovation. So I think in this group, in this audience, we are very well aware that there is no question about the value of data. So that's a hypothesis 1. Can we go to the next one, please? The second one is that we often discuss about privacy as a barrier for data and as a barrier for better innovation. And when we talk with the patient community, and there is evidence of that, it's clear that patients they have no problem to share the data for research and the greater goods purposes. Where is the problem is when they know what is done or sometimes what is not done with the data that has been shared. And so we just want to be clear that that's where we need to act is on how to use the data and the governance of data, not on the fact that patients want or don't want to share data. So there is really, we come back to the trust issue that Hadley Clark had put on the table. And so we talk about the trust divide here. Hypothesis 3. And so we hear in all the commercial conferences the potential of AI, the potential of digital health, the potential of digital devices. But there is also something we hear less often. There is really a rift between where we are today and where is the potential of digital health. And so because of some issues and the sharing issue that Nevin will develop first later on today is one of many, but it's really important to acknowledge that yes, we have great potential. AI is achieving great things. Big data, machine learning, all of these things, the buzzword of today, are achieving great things, but we are far from the full potential of these activities. And actually, what Tom and Matthias will come to present us is how one part of the solution to address that. But let's not assume that it's only positive and there is only potential. There is also plenty of barriers blocking us to get to that full potential that we need to address. And the last hypothesis is actually that to address these barriers, patients and patient organization are key. They are the one that can, this moderator that can do the different needs for massage in the system to make sure that the design, the generation, the analysis, the decision made on data, the management of data is actually fit for purpose. And so there is a real, patients are the key there. So that's, if we want to progress, let's work together with the patient community. And so with this 4 hypotheses of work for today, I just want to give the floor to you, Nevin. So welcome, happy birthday. And I let you introduce a little bit who you are and what you want to share with us today. The floor is yours.
Hi, Nicola. Thank you, and a pleasure to be with the group today and to contribute by sharing the ICODA case study with you. I'm the scientific project lead for ICODA, the first driver project that we put in there, as well as a member of the executive team. Let's go to the next slide. So just wanted to remind us that access to data lives within open science, and open science is argued by many as the means by which we will make the most advance in terms of the challenges that face humanity. Next slide. In terms of data sharing, it's absolutely unassailable that the benefits are quite substantial right across the gradient of stakeholders. Our experience, and I think this is borne out by others, is that even the COVID-19 pandemic has not been sufficient to really move the needle in terms of timeliness of data sharing, at least when it comes to randomized controlled trials. And so now's the opportunity to reflect and to think about what we will do differently. Next slide. So what is ICODA? It's an ambitious program. It's a global program. It's not for profit. The funders are from the group at the bottom of philanthropic organizations. And our hypothesis is that if we have a properly constructed data research lab, then we are able to provide health research data at scale to data researchers around the world. In turn, they create scientific insights that help to address COVID-19. If we do this right, then it's a blueprint, it's a way of working, it's a platform that will be available for future pandemics. Next slide. Now, to do something that ambitious, you have to have a kind of a structured approach. I won't go through all of this. I'll just tell you that we were very focused on ensuring that we were not burdened by past experiences in data sharing, but we were informed by them, that we were part of that ecosystem. We view the public patient involvement as key. Really, this has to serve the entire world, not just the affluent blocks of the world. And even if I had the most beautifully constructed data research lab, if I didn't invest in making the results of that work high quality research, reliable results, we would not be doing a service to the pandemic. And so this takes us to start with questions people care about, research questions that allow you to move quickly in finalizing the platform and the infrastructure, but also get results out. And I led the first of these. So what was it? Next slide. It basically said, and this is from April, there's lots and lots and lots of randomized controlled trials studying potential treatments for COVID-19. How on earth do you make heads and tails of all that information? Next slide. So if you think back to the moon, getting a man or eventually a woman on the moon, it takes vision, ambition, coordination, multidisciplinary action. So what was our vision of putting a human being on the moon? It was to imagine that we would have clarity around what drug to use for which subgroup to address COVID-19. How do you do that? You answer these questions on the left. If you answer these questions on the left, guess what? You're able to do better studies for those areas where you still have question marks. You better use of your resource, of your time, and the information in the scientific virtuous circle really works much better. Turns out that most of these questions on the left can be answered by summary data. So means, proportions, Kaplan-Meier estimates, and those are unencumbered by the typical considerations around patient privacy. And so we thought we had hit the sweet spot that would enable us to turbocharge and to go super quickly, getting the RCT data together to really inform public health policy. Next slide. So this was our value proposition. If we can harmonize and have a good data dictionary around the summary endpoints, we can put all the trials side by side. We can have these fantastic visual analytics and standard meta-analysis tools to really help move things along, reduce the threshold. And most importantly is we can get some clarity on subpopulations and secondary endpoints. And those are the things that are very hard to address in a single trial. So you need the strength of aggregate data sharing. Next slide. Here's our progress after a year. We have had quite a bit that's been done. We have 10 pharmaceutical companies signed up with us. We have some data sets, but we haven't yet achieved our vision at scale. So let's look at why that might be. Next slide. I obviously will not go through all of this. I'll just call out a couple of them. Please review this, and Jan might tell us more later. But really, any organization that is big enough and well-funded enough to do a quick trial with a repurposed drug is also complex. And that means every discipline in the pharma company or the academic working group has to agree to do this work. That takes a lot of time. And then if you go straight to the bottom in the teal, one of the things that we've discovered, which is probably the real nub of the issue, is that those who provide data see exclusively downside to doing so, almost. Those who use the data only see upside, and hence there is a gap between the two communities. The incentives are not aligned between the two, nor are they aligned for those who are generating the data in the first place. Next slide. So concretely, to us, that meant what we thought was a burning platform turned out wasn't. And so that's something to work on. Next slide. So a page from history on the left-hand side, 1954, Rand Corporation had built this fantastic computer, and they thought that, wow, this might be a little hard to get into everybody's homes. It was expensive, it was hard to do, et cetera, et cetera. That's data sharing 1.0. What happened 50 years later? We have an iPhone. That's data sharing 2.0. That's what we're trying to get to, the iPhone version of data sharing. Next slide. How do we do that? Again, very clear, long list of things. These have been talked about for some time. I don't know why we're still talking. It's time for action. I would say the one that's going to have the most impact is the one around incentives. It's going to drive Most of the others, some of the things on the top are ideas to make sure the incentives get enacted, particularly with funders and policymakers. Next slide. So one thing about me, you don't know me, this community doesn't know me, but I refuse false choices. I don't think we're in an area where for incentives, we want carrots or sticks. I think what we want is these beautiful French toast sticks. They're delicious. They're kind of cute. They're cool. You want to have one of those. They hit the sweet spot. That's what we want for data sharing. Next slide. And so what do? We have to remember to drive incentives and accountability. Who are we serving? We are serving the patients. The patients are in turn served by their clinicians. Those are the two critical sets of stakeholders that we have to pay attention to what is on their mind. Just giving you a sample. Jan will tell us more about what's really on their mind. Next slide. So I summarize it this way, really 3 key things to do. If you're conducting, designing a trial, your job is not done until you have shared the data from that trial. That is what allows us to get even more investment and value out of your investment, pardon me. Those who fund the trials, you have to hold your investigators accountable. Lots of clever people can figure out how to do that in a good way. And those like me, who want to set up systems or who work with data from other people's trials, we've got to make it easy, efficient, and we have to work to ensure that the results are reliable. What can patient and professional medical associations do? Ask your questions. The questions you care about will undoubtedly make it a requirement to have this aggregate data information available. Keep asking, hold the researchers accountable, and they will have to deliver. Next slide. Now, I'm a statistician. I've designed, I don't know how many hundreds of trials in my career, my teams have. I have full respect for the context within which the data was originally generated, the context within which patients and participants signed up to be part of the research. But I know we can get more information from all of that investment, and that's what we have to do. And so I leave you with this quote from Nelson Mandela, who says, if it's a tough thing you're trying to serve, be open and receptive to other people's ideas. You'll come out with a better solution at the end. And I look forward to all of your suggestions. Thank you. Back to you, Nicola.
Thank you very much, Nevin. And so great presentation and great initiative, ICODA. I have seen a question from Jenny that is asking about connections with an existing initiative. So without asking you now, but maybe in the Q&A, if you can explain how ICODA has been playing with, I'm sure there's many initiatives that you have seen across the globe. If you can either in writing or later on in the Q&A, if you can reply to that question, that would be great. You have mentioned the need to address the primary use and secondary use of data, and I know that Matthias and Tom will come back on that. In the meantime, Jan, if you can come with us and actually react a little bit on what you see is the state of sharing on COVID-19 data and what resonates with you or doesn't resonate with you.
Well, thank you so much, Nicolas, and extremely interesting presentation by Nevin. Thank you so much for delivering that. Of course, I mean, commenting ad hoc about this just takes me back to thinking about where does data benefit the patient? Because I think one thing that Nevin clearly presented is that access to data benefits all stakeholders. That's, let's say, the ideal world. The reality that we see is that there are huge amounts of interest everywhere because there are so many interests. Everybody keeps sitting on their data nest and keeps it because they want to be the users that use it. Or they want to be the ones that use it, but they don't want to be the ones that share it. Because then the benefit is elsewhere. And I think in the pandemic, we've learned how important it is that, let's say, the primary purpose is to pull it together because there's societal benefit. there's a general public benefit and there's a patient benefit. And probably something that is really, really important always to remind is, where's patient benefit when they share their data? Why did they share the data and what for? And there's a difference between what the general public wants and what patients want. And if you just transport that to COVID-19, the general public, of course, wants to end the pandemic because there's burden on citizens, there's restrictions, there's health risks, there's a financial burden, there's economic burden, there's a lot that is a burden on society. But the interests of patients are different because the patients, they have their life on the line, and those that are affected by COVID are at the risk of, let's say, losing their life to the pandemic. So the primary interest should be to protect those. And how can actually then a data model and data sharing and so on serve the primary interest for patients? That's one of the questions we need to ask ourselves. And I mean, somebody said, if you want to move cats, move the food. And that's probably where we need to think about in data is how do we make sure that we move the food to the place that the primary interest is actually to serve the patient. The secondary interest is the interest of the respective stakeholder group. And that's where we come back to, let's say, the initial statement from the April workshops in the beginning, those 4 hypotheses is, I don't think patients are primarily interested to, let's say, sharing for the greater good of mankind. They share out of personal benefits. They actually want to make sure the pandemic ends, and they want to make sure they're protected. And I think that's what we need to always have in mind, also now in the pandemic. And what I can see at the moment in the pandemic is that more and more citizens develop scrutiny because they feel they're feeding into the system, but they're not understanding why decisions are being taken. They don't feel being part of the process. They don't feel they're empowered to take decisions. They again have the experience that decisions are being taken on behalf of them because everybody knows better what's good for you. And I think that's something we can probably discuss after the next presentations also. How do we define an ecosystem where all the food is moving to a place where patient benefit is at max and everyone else benefits too? And that's what I'm looking for. And that's why I really appreciate that presentation as an eye-opener, which is so tremendously important to bring all the different data pools together to really understand what's going on in COVID-19 and how we can battle the crisis.
Thank you, Jan. And so I remember when we were preparing that Neveen was pointing the rift between the potential and the reality of where we are, and she was pointing already the incentive issue or the food issue, as you put it here. So with this, I would like to ask Matthias and Tom to actually explain a little bit more of their work, but maybe already to keep an eye on this idea of the incentive and what's part in your project, H2O, Health Outcome Observatories. What's the incentive chapter that might help change the issues that both Neveen and Jan described? So I give you the floor, Matthias, up to you.
Yeah, thanks a lot for the nice introduction, and I think this is really key, and I'm happy that I think we thought about this kind of incentive. I don't know if this is the food would fit to this, but maybe the first to have a kind of a little introduction is when we thinking of the COVID part, then obviously the main target was to decrease mortality rates, which is the core, where the defining moment of medicine maybe was 100 years, so a couple of 100 years ago, that we are thinking of an external agent, which is, threatening our life. And at that time when, we were thinking of infectious diseases and how to deal with infectious diseases, we're talking about 1810, the average lifetime was 40 years at least in most of the European countries here. And now, at that time we were focusing on diseases, or, basically ignoring to some parts the patient, focusing more on the organs. And then that helps us obviously with Koch and Virchow to find some kind of cures for infectious disease at that time. Now we are talking about a lifetime expectancy of 80 years. And now the next 100 years, I think, will be basically determined by chronic disease, although we are dealing with a pandemic now, but the majority of disease obviously is chronic disease, and then the outcome will be health. And that's the reason why we are thinking about the health outcome observatory. And the important thing about health is that you cannot define health anymore from the disease perspective, which is usually a perspective you have as a clinician. You have to define it from the patient perspective, otherwise you cannot define health. So this is basically the starting point that we say, well, there's a shift because the majority is chronic diseases. And when we think of a different outcome, which is the health outcome, another colleague, a rheumatologist from Stanford, Jim Freese, said, well, the challenge of the future is to compress morbidity, so to increase the healthy life time expectancy. So this is a starting point. And that was the challenge also to say, well, we do need to have something which addresses what Naveen just said, kind of a structured way to have standardized data to assess health from the patient perspective. And maybe I can get the next slide. So once you start for this, you come across a couple of challenges, obviously, that so far, and this is more or less a success story when we think about increasing life expectancy to think of an organ or disease-oriented medicine, but it's obviously not so well suited if you think of chronic diseases, or then we have to make those kind of philosophically shift from the clinician view to the patient view without losing the understanding that the kind of defining moments obviously is also some kind of disease you're suffering. So we do have a challenge that's between the dialogue between the doctor, who is usually making suggestions about your care, and then the outcome, which is from the patient defined, which is the health status. And then to facilitate this knowledge, obviously you have to find a way that all of the stakeholders are interested in the assessment of the patient health status from the patient perspective. And the next slide will show you probably the problem a little bit further, because I'm trained as a clinician, so I started as an internal medicine doctor as well. You can assume that in an individual encounter, you are interested, obviously, to help your patient, but the information you collect is a narrative information, it's a detailed information, including all the social background and probably also the aims from the individual patient when it comes to starting a cancer treatment, that it's not kind of off-the-shelf solution there. But to have data together, and Naveen just said this, we have to get the patient's voice into a number, and this is always a kind of reduction. So you have to say, well, how do you feel, or can you walk a mile? You have to put it in the number to have a kind of a structured data. So it will be a reduction, and then the reduction of those kind of needs to be also in a kind of a reasonable way. So this kind of getting from the comprehensive individual picture to this kind of reductionist, which is essential to make a description, obviously, for the cancer patient, for the lung cancer patient, or for the IBD patient, is a kind of reducing the person again to a disease oriented. So we have those kind of two perspectives, obviously, which is the challenge to include the patient voice here in a meaningful way. Next slide, please. So, and this is where it comes to the incentive part. So I just close. I think, well, we do have, let's say, 4/4 of stakeholders here who are interested in health as reported by the patient. And one, obviously, is the clinician, I assume, because you're asking, how do you feel? And you feel a little bit better when the patient obviously feel better getting your treatment. So I do believe that this is the starting point, which is the patient encounter, which is the left side, so the upper left side. So and then the clinicians are obviously interested to have a kind of trajectory. They're good data, if you have a trajectory of metastatic breast cancer using PRO data, patient-reported outcome data, then you can increase also mortality rate. But you would like to know how the patient is feeling, and you just transfer those kind of talking to a number. So this is a kind of one starting point. And obviously the patient, I believe, is very much interested to help the clinicians to get those kind of information. So this is incentive, which I think doesn't need to be a financial incentive, that once the patient think, well, this is important for my individual encounter, that my physician knows if I'm have diarrhea, if I'm have shortness of breath. For COVID, we did this here, obviously also at the charity, is that this is important. So the patient, he is interested to get laboratory results. So I assume that he is also interested to inform the physician about his own health status. So this is the individual data level. So we are not talking about any financial incentives here. And now to use those kind of data for academic use, which is the other side here, or it's for the industry use, of comparative treatment effectiveness, pharmacovigilance, I think we can use the same data, which is then the aggregated data level. And then obviously this is also interested for patient organization to say, well, this is our, this kind of group, suffering the most because this has a certain socioeconomic status, certain health literacy levels. So I truly believe that we have to think of to collect those kind of patient-reported health data at one place in a way which is meaningful for all the kind of four stakeholders. And this is a challenge for the Health Outcome Observatory. Next slide, please. So next slide. So just so the idea is very essential. So we obviously would like to improve the quality of care by including the patient voice, and to do so in an empirical based medicine, obviously we have to have data, which is a kind of reduction. So this is the way we would like to do it. Next slide. So the essential, how we do this, if we go a little bit deeper, so what we think of what is good or we are aiming for is where I have some kind of European hub which is accessible to patient organization, obviously to researchers, and there will be legal entities who are trying to do this. And Tom is going to talk about this a little bit later. And at this place, basically, you have access to the standardized data. And this is a good thing at the moment because we don't have a kind of an accepted standard. We don't have competing standards so far for PRO data. There's only one, which is usually used, which is LOINC and FHIR standards, which we are using. So we have this one central place, which is, and also what I think is very important from Nivine's talk is that you don't have to ask all the legal entities to get this data because it's sitting there and it's all secondary data, all anonymized data. And that will empower obviously the patient voice in this and then ultimately inform medical information by collecting those kind of information. Next slide. So it is key what I think that we, in an empirical based data or an empirical driven medical system, which we have, we can only include the patient's voice if we find a way to make this into a number. So this is then, but we have to do it obviously by creating the communities, which is this kind of philosophical change about clinicians, and researchers and patients, what we do in H2O, or we try to aim to, and this obviously can only be done to be meaningful for the data and for the content which we are measuring with patient organizations. I just listed some of them. We are doing this in 4 countries at the moment. It is not comprehensive here, obviously, just to get a better understanding. So, and I'm happy to hand over to Tom now.
Thank you, Matthias. Could we have the next slide, please? So, as Matthias has said, this is to our knowledge, the first attempt to do this at scale in Europe, to collect both patient-reported outcomes data and clinically reported outcomes data, create an integrated outcome set, and then to, first of all, to make this available to clinicians or to caregivers and patients at the point of care, and secondly, to give other interested parties, both healthcare providers and innovators, regulators, HTA agencies, patient organizations, the access to the aggregated data essentially for research purposes and for the purposes of innovation. and to an extent also, as I say, regulation and resource allocation. If you go to the next slide, please. So our plan for doing this is to create demonstration projects essentially a big demonstration project, starting with 4 national observatories in Austria, Germany, the Netherlands, and Spain, in 3 disease areas, so in inflammatory bowel disease, in diabetes, and cancer. And to, first of all, to have an approach which means that we are collecting standardized data across all of these national observatories and across all of these diseases. So the first thing that we're going to have to do is to create standardized outcome sets, and to do this in a way which integrates the perspectives of the different actors in this, so patient perspectives, caregiver perspectives, epidemiology and scientific perspectives, but making sure that we get to an integrated outcome set which is standardized, but also meaningful, interpretable, and leads to action. And as I say, then to collect this data in a prospective way, using these separate national legal entities, and to create a common data model, which is, we're planning to do this using the OMOP data model. And then also, as I say, to make the aggregated data transparent and to regularly publish our progress on this work. If you could take me to the next slide, please. So the time frame that we're working with is to, in the first 2 years, is to create these standardized outcome sets, to work on the technical platforms, the governance processes, and also to work with the many stakeholders that we're working with to ensure that we've got broad support for the approach that we're taking. At the end of the 2-year period, we're hoping to have the core of this in place, and for us to then begin working with patients to collect patient data, and as I say, to, in the first instance, to begin to use this at the clinical interface, so that patients can use this in communication with their caregivers, and then to slowly build up the pool of aggregated data so that secondary data uses can be enabled, and to begin to slowly generate funding streams out of the use of this data to create a self-sustaining system, which would then be hopefully take us through to the end of the 5-year funding period, which we would, where the money from the European Union expires, and then in the longer term to lead to a self-sustaining system, and to broaden the geographic footprint of the project, and also the disease footprint of the project. And we believe this will empower patients, lead to better data availability, and to enable a move towards value-based healthcare models. And I think this then takes us back to the incentives a little bit that Jan was talking about. One of the core hypotheses or beliefs which have led us to this project is that the best way that we can all maximize patient benefit is by measuring outcomes in a standardized way, and making sure that we are measuring the outcomes that are most important to patients, measure them in a standardized way, and then make these outcomes transparent, such that all of the stakeholders and system actors can optimize what they do to deliver improved healthcare. And they essentially optimizing around these outcome measures, because that's what healthcare systems should do. They should deliver better outcomes for patients. But in order to do this, you have to have robust and reliable data around whether or not you're achieving the outcomes that patients want to see. And I think, as Matthias has very clearly laid out, this needs to integrate both clinical outcomes and outcomes from a patient perspective. So if you take me to the next slide, please. So this more or less lays out this on a timeline. And as you can see, setting up the national observatories, setting up the pan-European observatory, ensuring that we have consistency, standardization and interoperability of data, and then beginning to create the data gateway as this comes to life, and building over the long term the extension to other disease areas and moving towards a self-sustaining model. If you take me to the next slide. So I think we've talked about this, the three main pillars that we're working on: establishing sustainable national observatories with a governance model which is broadly supported by the community, working through a multi-stakeholder collaboration approach, leveraging technologies as existing technologies as far as we can, and building upon existing networks, and then building on the existing knowledge and initiatives, and melding this to the or integrating this into this innovative approach and governance model. So if you take me to the next slide, we think this is will provide benefits to all of the involved stakeholders. And if you take me to the next slide, please. This is what we've achieved in the first 12 months. We've, I think, established robust concepts around governance, data security, ethical approaches. We've laid out a technical architecture for building this infrastructure and interoperability. And we are fairly close to defining the outcome sets in the three disease areas, and have laid solid foundations for observatory management and the scientific communication. We have patients and patient advocates involved and integrated into many tasks. If you go to the next slide, please. And this is the link to our website. We are very open to all of the critical feedback that the participants here can provide. Thank you for your attention.
Thank you very much, Matthias and Tom. Maybe just, I'm not sure the whole audience is familiar with IMI project, but I just would like to remind these are public-private partnership where I'm not sure, I think I've seen around 30 members in the consortium. You might
23 or 24, I think, but it's a large consortium, yes.
So just wanted to position H2 as an IMI project, public-private partnership, just to clarify. We have had a few questions in the chat and the Q&A. So Matthias, there will be a question for you on the collection point of this data. And I think Tom, two questions more for you on the role of AI and on more technical aspect as well in the Q&A. Before we get to you, I just wanted to have the reaction from Jan on these questions and on the approach that you have heard, Jan, from your patient perspective.
So thank you so much for that, and really an interesting project with all the different segments. And I think it's very, very important that systems like that are being built with a solid governance structure and having patients involved in the consortium and the governance and the execution, and especially on the design phase of these projects. Because I think, or probably just to take a bit of a round, I mean, I've recently been reviewer of public funding of projects like these for governmental funding. And it was all about digital and AI and so on. And it was actually my task as patient reviewer to look at the patient engagement section in the proposals. And one thing I always looked at is what kind of substance is behind the patient engagement and empowerment piece, and how is the digital technology really empowering the patient. So how is this being defined? And I think that's a very important point to look at, because what I often see is that decision support systems are being built to support the decisions of physicians in consultation of the patient. They are not being built to actually have actually two phases, one informing the patient, one informing the doctor, and then having the doctor and the patient having an informed decision or an informed discussion on equal eye level. And I think that's a very interesting bit to look at, is to think about how can the individual patient actually being served by systems like that they understand how they're doing, because they don't want to feed an app just to feed an app. They want to feed an app because they want to keep track of how they are doing and potentially comparing how other patients in the same situation are doing, which is a benefit of big data. And then also knowing what, let's say, the overall outcomes will be. And just as an example, I've been feeding my COVID-19 vaccination app since I got the first and second shot, but there's zero information about what others are feeding in. And at the same time, I'm getting all the speculations on Facebook, what kind of side effects people have on all the different vaccines, while I'm feeding a machine that knows. So I have no chance actually to get anything out of that for myself, just to feel that I'm a bit empowered about the whole process. And I think that's important to think about when designing such systems. Don't think just about provider value, think about the patient value behind that. And that's the second part of it. That's the individual patient, and the other one are patient organizations. And I think, Nicolas, you were mentioning that. How can the patient organizations be empowered by the data that's being generated by these systems to support their community? How can they understand what kind of data is being collected, aggregated? How can they raise their own research questions on that to understand quality of life trends, subgroups, subpopulations, patient preferences, whatever, to actually improve their services to patients, knowing that they're in touch with the patients day by day and much more often than their healthcare professionals. And that's the second part of patient empowerment that I think we need to spend a lot of time at the design stage to think about how can these systems inform the patient community to work with researchers, work with policymakers, and support their patient community. Because I think they can understand, they're trained for it. They can actually help to put the data in context, and they can then help the researchers to raise the right questions to the data that they've gathered. And I think that's the second bit of thing that I'd like to see in projects like these. And thank you so much for really driving this forward. That's really important.
Thank you very much, Jan. Matthias, would you like to take a look at the question regarding the point of collection?
Yeah, maybe I can also, combine this with some answers to Jan. Thanks. Yeah, yes, and so sorry that I haven't been clear on this. When the lower quarter, which was the patient, obviously as a stakeholder, is at the H2O project, we are providing this information you were just asking back to the patients who are answering this. So this is really that you see a trajectory of all the patients who are answering this based on their condition and maybe some other socioeconomic factors that you really can compare your trajectory with a certain drug you're under. For example, if you're a lung cancer patient, that you know how you're doing in comparison. So which I think is very important to a certain type of patient. When you think of, for example, type 1 diabetes patients or in Crohn's colitis patients, there the entire treatment is much more driven by decisions of the patient themselves. So we as physicians are more kind of assisting these kind of patients. When you think of an elderly, let's say lung cancer patient in an end stage situation, at least in my experience, it shifts a little bit, not for all the patients, but it is a different type of situation where probably you use your PRO data more to inform your physician about adjusting some kind of treatment. So it's less important how you're doing compared to other patients. So this was a challenge with the H2O system to address very different situations where you have somebody who is really in charge of his disease, like a type 1 diabetes patient. You wouldn't call themselves a diabetes patient. You would say, I'm a person with diabetes, obviously, and other patients are doing differently. So the other part which comes in the chat, and Nicholas just asked me, and again, I'm sorry, that was also a reason where because we used the patient community, and there was exactly coming up this question, and that's the reason we changed the design. And I wasn't clear about this, that all the PRO data actually are not collected at the point of care. They can be collected at the point of care like a lab result, but they can also be collected, and they should be collected to be informative, the 362 days, which is outside the point of care. So you can enroll as a patient, even yourself with not having a kind of physician who enrolls yourself in the H2O system, just to do what Jan just asked for what you do. So the PRO part will sit at some place at the observatory. And then you can basically allow your physician to see the PRO data. The clinical data obviously are sitting at the point of care because that's where they're collected, and you allow those kind of data to be used in an aggregated form to make aggregated information about your data. So that's the idea. So it's kind of a hybrid design, but this was exactly why we use the co-creation with patient, that to see this. And I'm honest, I would have made a different when I would have been just thinking for my clinical hat on. I would have built up a system which is, built at the charity, because we are. So that was kind of exactly the thing what we are doing here. I don't know. I hope I was clear. So the PRO sits at one place to have the patient journey with different providers, and the clinical data we hope we can collect across the patient journey from the different hospitals will participate.
I mean, I think the other thing to say to complement that is that we want to make sure that we collect the patient-reported outcomes data in a device which is like a mobile phone, or almost certainly will be a mobile phone. So it's something which is very convenient for the patients to use, but that will be the primary way that we collect the patient-reported outcomes data, and that we will integrate at a high level, a data set which is integrated between the clinically reported outcomes data and the patient-reported outcomes data, and report that back to the patient as well. So I hope that answers Lode's question as well. So
I think it is. I've seen his comment in the chat. Jan, you wanted to comment on that? Okay. Tom or anybody else, any comment on the role of AI to aggregate the patient narrative?
I think that we will, certainly within this project, it's not a central part of this project, but in terms of, I guess you can look at this in two ways. You can look at structured data approaches and unstructured data approaches, and both of these need to complement each other. And in terms of doing things like social media listening, so making sense of what you're seeing on Facebook, Jan, or any other social media platform, or any other form of unstructured data, it does make sense to use machine learning approaches and AI to try and make those signals more intelligible. But it also, we think, makes sense to impose a certain structure on the data as far as you can, but to complement both approaches. Both approaches are complementary to one another. And the the drawback of the structured data approach is this has to be designed in, and you are constrained by the structures that you impose on the data. But this means that if you haven't conceived of, for instance, an adverse event which is completely unexpected, you won't see that through your structured data approach, or you'll not see it in be able to perceive it in the way that is probably the most intelligible way. But as I say, you need to use both approaches, and I'm sure Naveen has got plenty to say about this as well as being from a biostatistics point of view.
Before Naveen, you interact, I just would like to ask our great support team to already put the link for the group map so people can start to log in group map, and we will be more efficient in the shift after that. But in the meantime, we can continue the discussion. Naveen, tell us what you have in mind.
So I like everything I heard from Tom. I would just add, when it comes to physician notes or anything that's not kind of standardized in terms of the nature of the data you're trying to work with, you're going to have selection bias, and that bias could make it completely unreliable, somewhat unreliable, or pretty okay if you've got other sources that can complement. So just because you can do it, you can hit the button, apply the NLP or the whatever it is, doesn't mean you should. And even if you do, you want to be mindful of the nature and the context of the originating data before you can say, here's what I think it's telling me.
Thank you, Naveen. And Jan, anything there? I guess I know what you would say, but so I was surprised you were not coming earlier on that one.
No, I'm not sure why that refers to that, but it refers to the role of the patient organizations. I was still struck with what Tom was saying before, thinking about social listening. I think, leverage the power of patient organizations, because I sometimes feel we're still stuck at a time when patient organizations like today didn't exist, who can't deal with data, can't deal with researchers, and can't collect data. While we're in the patient community talking about patient preference studies, running surveys, doing whatever, we're still talking about cherry picking patients from here and there to do focus groups, and let's say trying to look at social media for unstructured data. We would be willing to generate data. We have, in 23 cancer areas, we have umbrella organizations with an outreach to members all across Europe who have thousands of patients in their community. Similar applies to rare diseases and others. Why don't we utilize the power and the experience that patient organizations have to actually gather data about patient preferences, about rare outliers, which we know from our forums when we design these kind of surveys on rare adverse events or whatever. We can help generate these data, but quite often we're not involved in this, and probably we need to rethink, because we're often asked to spread surveys of research consortia, and we by default deny that, because if we don't have any access to the data and see the results when the press is seeing it, where's the incentive for us to participate just for the great good of mankind? We want to be research partners in there. And if we can co-generate data, which we also co-own, we might be willing to contribute to this, and you will get the best data that you probably ever had outside of a clinical study about these things. And I think that's what we need to, that's why, remember the image that Nicolas was showing earlier on from the April workshop. We need to think about collaborative data structures where patients are also co-owners of data. Otherwise, it will be very difficult to actually implement these kind of models. But I'm not sure, Nicola, whether this was actually the ones that what you wanted me to refer to.
No, but I think I know it's a question of the role, and patients that, as a partner, not the patient that you invite at a key point in focus group, but really at partner from design to generation to analysis and to decision making, with this incentive that indeed, as you mentioned, that should be access to it. So the role of patients, whether it's patient organization or the patient community at large, is really still something to be I think we talk about often about systematic patient engagement. I think we should make a systemic patient engagement where the patients are really part of the system and not the one that we invite when we think we would like to get some feedback. And so I think that's really an important part of the puzzle there with this incentive thing, which is actually with this discussion, even if we had preparation with this discussion, I realized myself that this incentive part is actually very central to the issue we are trying to solve. So that's probably one of the key issues to address first. If we have time, we'll continue the discussion. I would like to move a little bit to engage our audience and to go in a group map. Can you please, Maxi, please put again the link in the chat? And I just would like to make sure we have everybody going there. I see only 10 participants at this stage in the group map. I just want you have on screen right now an example of the group map we have done on patient experience data, and more precisely, even before we talk about patient experience data, patient impacts, where we try to actually put together all the type of impacts patients are facing, way beyond the clinical aspects, way beyond the regulatory aspects, and just to take a look at that. It was yesterday, and the people in the room fed very well this first boat. I just wanted to give you that because actually we are just a couple of steps later on here now today. Is once we have the data, how do we manage it, how we standardize it, how we share it, is the question. So we have 21 participants on the group map. Let's maybe focus on that. The first question is just to know who is contributing, just to tell us who would be we can maybe share the group map screen, please, Elizabeth. Thank you. You can tell us which type of contributor you are. And again, the others is quite big. So maybe you can say for the others in the chat which type of stakeholder group you belong to. It was the same yesterday. Thank you, Diana. So just wait for a few seconds and I move on. Okay, so majority of pharma companies, and then we have the other group, and we have patients and patient organization that together would do 18% and 11% researcher. So that's for the 30 people that have logged in the group map. What about moving to the next question, please, Elizabeth? It's a little bit of a warm-up question. Before we really deep dive into the role and the value of patient contribution at different key points. It's more a personal reflection. In your not professional experience, if you're working in pharma or as an healthcare professional, but more as a patient or as a caregiver. So what was your experience in sharing data? So yesterday we were asking about like sharing your experience, but in this case, sharing data, what were the opportunities that you faced, and how did they happen? Was it a positive one? And then how would you describe it? And actually there was no real opportunity to do that, and then why not? And so if you can just spend a few minutes to help set the scene. Thank you. I see the COVID app, and I will be curious in the chat if you can tell us if it was as a citizen or as patient that you were actually contributing data. That will be interesting, coming back to the earlier point from Jan. We have some healthy people that don't need to share data. The absence of feedback loop, very important point. And maybe Matthias and Tom, is there what will be the feedback loop in the system that you have designed? Because I think there is, but how it would work?
Yeah. Shall I just, Thomas, shall I? Whatever.
Yeah, go ahead, Matthias.
Yeah. So the idea is basically, like a Swiss Army knife, that we have those kind of one place where, you answer your health status information. It could be a little bit more than that, obviously, and then you get this kind of immediate response that obviously, how do you compare to to patients in a similar situation, getting a similar upfront treatment type of treatment. So this is one thing, and then we hope that we can extend those kind of very basic feedback based on your reference point with having access to your clinical data, so that you're in a certain treatment situation with your clinical provider, and you can use your app and open it and say, well, these are my lab results, for example. And then we hope, obviously, that we use those. And because somebody, I think in the chat, said, well, the point of care is not the hospital anymore. The point of care is outside at the patient home. And then we obviously would like to get as much information as possible at the point of care at the patient's home. So we hope that we can use those kind of H2O app also for kind of communication. We have a kind of a pilot project in Berlin, where we use this for prostate cancer patients, where we use this as a communication tool already. So it's a communication tool that we don't have this kind of black hole where you report something. So it's really facilitating the encounter and having bidirectional information. Hope that answers the question.
Yes, it does. Thank you. And I see the answers are coming in. So don't feel rushed. We'll move to the next question, but the group map will stay open until the end of the week. So don't feel rushed to complete it. I have seen some reasons. The absence of feedback, the black box is something that is coming by quite often as a reason not to share. It's interesting to note that nobody has stated the lack of remuneration for that data, which is, for some reason, some people have this, they start from the idea that patients should be remunerated, which could be one model, but I don't think it should be the model on my side. But it's interesting to see that nobody has put that explicitly on the table in this group. So next question on the screen. So it's focusing more a little bit on, well, if patients, it's an hypothesis of work, the hypothesis 4, patients, the patient community, the patient group are key to actually create the bridges between the different stakeholders, allow some mechanisms for sharing the data, and take an active role in stewardship, maybe, of the data. So what could be these roles or the value patient would bring? And so you might actually articulate your answer either as a role or as a value you will see at in the 4 boxes that you see. So design, analysis, decision-making, or management, governance, and stewardship. So please be specific with a V for value or R for role of patients. We can start to capture that. I see a lot of V, only one role for the moment. Because maybe I have a question for you, Matthias. When we talk about primary, secondary use of data, and also the primary objective of studies, what's patient relevance is rarely actually the primary objective. And so how would you deal with that when the patient comes to the table, they express an unmet need, and actually they find this specific question pushed down the priority list in the actual study. So how would you address that, and how do you address that today in your current practices?
Sorry, I think my internet connectivity was a little bit unstable. So it is, the question was, how we address if the patient comes there as an unmet need in the design part of the project, or in the rollout part of the project.
In the design part of the project, when you design the protocol of a study and the objective of the study, it's quite often that the patient's priorities are not the ones that are listed as the objective 1 or 2 of the study. So is there a way to address that?
Well, I think in the design part, it's a little bit easier because, we do have obviously Delphi processes going around to say, well, what is the health outcome? If you're chronic colitis patient or diabetes patients, what you're caring about? And then obviously it is very different because people are caring about different things, and then you try to get the best out of it in a consensus process. So there, I think it is a little bit easier, but I think the painful question is a little bit, once we are up and running and we have defined the sets of outcomes which we think is important, then there is and Nivine was correct, and that's kind of, you make nobody really happy, because you have this kind of standardization which we all believe, and I'm very happy that you put up the 3 slides in front of it. Of course, we believe in that there's value in some data, but then you have to live with the situation that once you have a standard which you can work with and which is structured, and you don't go into the hassles Nivine just mentioned, that you want to call everybody to pool the data, then obviously we have a kind of a set, and how flexible this set will be if patients are coming, well, there's something missing. For example, there's a new drug, and we we should take care of diarrhea, for example. I'm not really sure how flexible we are. So have this kind of innovation circles of the H2O project. So and sometimes patients are asking me, well, it's all nice and you listening to the patient voice, and now you make me to a number again. So this is what we are hearing, and we are doing this at the Charité ePro assessments for 20 years. And they say, well, this is nice, you're listening to me, but now I have to put my fatigue score from 1 to 5. So what is this? So you're not really honest here. So that, and he's right, or he or she is right. It's a number again. So it's less than somebody's talking about his fatigue, or that fatigue is not enabling him to take care of their grandchildren. So it's you're missing those kind of lively situations here, which is kind of the contribute when you want to get structured data. So I don't know if this answers your question, but yes, there are limits. But I think the advantage, obviously, to have something which is reliable, standardized, and valid to some degree, and it is probably groundbreaking, because we don't have an agreement on outcomes from the patients so far at all. So I think this is breakthrough.
Thank you, Matthias. I'm looking also at the same time at the result. It's interesting that the one that seems difficult to start is the decision making, with a comment even about what decision making. And the what decision making also means that there is an assumption that some decisions are not for patients, or patients should not be at the table at all for some decisions. It's a perspective, but so important, because I think when we see, for example, the regulators or others, we clearly are moving in that direction. So also I see in the decision making an interesting one, like who should be able to access the data, and some of the first thoughts on the role of patients in this data model is really about stewardship of the data, because when it comes to some decisions, we cannot each time ask the patients if they would want to share the data for that purpose. So stewardship of the data and the role of patient organization to help that stewardship, I think at least personally I'm a believer of that approach and something we should explore. Tom, I see you have hands up.
Yeah, no, I mean, I think a little bit to complement what Matthias was saying earlier on. I mean, I think one of the, this is just it's a challenging system that we're working in. If you think about how healthcare systems work and how, to an extent, the plasticity of the system, how it can be adaptive to the needs and wants of individual patients. Obviously, really good caregivers respond to patients, I think, as Matthias was trying to say, as real people, not just as numbers, and try and do this as effectively as possible. But we all know there are cost constraints on the system. There are constraints in terms of organization. Certainly our perspective of this as a commercial organization is that we want to get healthcare systems to be as responsive as they can to patients' needs and wants, but also to lead to a situation which is equitable and sustainable. And so there are obviously some challenges around this, and this is, I think, what leads us to having to optimize for the benefit of a population or a cohort, rather than always optimizing for the individual. So we are trying to do as much as we can to optimize for individuals, but there are limitations to this. And I think this is something that, in terms of how we think about improving healthcare and, as we say, collecting standardized outcomes and optimizing for what is most important to a large group of patients. These are some of the things, I think the constraints of the system, which we all have to work with and think about how do we just make it incrementally, significantly better than it currently is.
Thank you, Tom. And so I think would be nice, and maybe that will be the word of the end. It's to in drug development, patient engagement has proven to be one way to actually help all stakeholders. I'm really insisting all stakeholders to better perform in their activity. And so when we come to the limit of resources, and that's on purpose, that this hypothesis that the current system is not efficient. The idea is to work with patients to make it better and more efficient. So that's where and how we can do that is clearly something to explore. And I would like to have a magic wand to answer that question today, but I think that's what we are all working on in the next few months and few years to actually identify where is the place the patient community can serve actually the whole system and the better health outcomes for patients. So with that, I just wanted to thank all the speakers. We don't have Jan. I think Jan might have gone already to his next meeting. So thank you very much to the speaker. Thank you to Jan for this great session. Actually, this input is feeding project like H2, is feeding the digital health project like we have in PFMD. I'm sure Nevin is also using the information there. And so we'll have continuing digital session. I think H2O will also have some calls for contribution to some Delphi phases as part of their project. So it's not, this today was just a touch point, and we are looking forward to have the next touch point with all of you in the next few months or after the summer, most probably. Thank you very much, and have a great day, everybody. You just last word, you will receive a quick survey to actually give feedback on the session and what you would like to see next. Have a great day and happy birthday, Nevin.
Merci. Bye, everybody.
Bye-bye.
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 Thanks. Thank you.